Dr. Carlson, can you see the agenda?
Yes, I can.
Okay, perfect.
And I'm just going to wait until someone lets me know to start. Give it a couple more minutes, I'm assuming.
I believe we have a quorum.
Oh, right. I see Mike. We do. We have Perry, Matt, Mike, myself. So shall we get
And
started?
Misty.
Oh, I didn't see Misty. My screen is doing something funny. There you are, Misty. Hi.
Hi.
So shall we get started then?
Let's start.
Okay. Welcome, everyone. Glad to be here. This is my first time doing this, so bear with me. Okay, the meeting is being held virtually and is hosted by the Utah Department of Health Center for Medical Cannabis based in Salt Lake City. Public notice of this meeting was provided as required under Utah's open meeting laws, and it was posted on the Utah Public Notice website. In compliance with Utah's open meetings laws, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following today. Written minutes will also be prepared of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 days after board approval. This is a good kind of orientation reminder. The purpose of this board is to review the available research literature and assist the Utah Department of Health and the Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualifying medical conditions. I'm going to just read the board members. And I know Jennifer is not here, although I'm not sure if that's necessary. I'm going to do it this time. And then we'll see. It's myself, I'm the board chair. Matt McGiff is the board vice chair. Perry Fine, immediate past chair. Brian Zender, Misty Smith, Jennifer Norris, who couldn't make it today, and Mike Moss are all members. And the Utah Department of Health staff include Michelle Hoffman, Deputy Director, Rich Oborn, Director of the Center for Medical Cannabis, Sarah Ponce, Senior Registered Nurse and Research Manager, and Lauren Heath, Academic Research Consultant. And thank you to Sarah Lalos for helping this be possible today. We welcome any visitors to our virtual meeting. If you are logged into the meeting with a phone number and not a name, please state your name now so that we can add your name to the meeting minutes. So I'm going to give people a minute to unmic if there are any people that need to identify themselves. A public comment period will occur at the conclusion of the scheduled agenda. You can select raise your hand, which is a icon that appears at the bottom right of your screen, and we will do our best to accommodate your request to make a comment. And we ask that you state your name, affiliation, and disclosures related to financial interests pursuant to the agenda item that you would like to address. And we'll limit comments to 2 minutes per person. As a courtesy to everyone participating in this meeting at this time, we would request that you place yourself on mute unless you are speaking to the group. Okay. I'm also, we're gonna just, before we move to the agenda, I just want to go over what we talked about last month. I think it helps to orient me to what our purpose is and what our strategies are. So this is going to be a reminder for most of you. Our goal is to create a medical program here in Utah and to sustain a functioning medical program. And we've outlined the key components of a medical program. And there are 3 elements that we've identified: knowledge and ethics, which would be described as a comprehensive body of knowledge that sets the standards for an ethical and principled practice. Second element is education for practitioners. There should be accessible evidence-based educational programs and platforms that serve as the foundation for credentials, licensing, privileges, and CME. And finally, continuous quality improvement and research. The program needs a means of continuously improving care, optimizing outcomes, and mitigating harms to help further the collective understanding of the scientific basis of illness, disease, and applied clinical practice. So translating those 3 elements into our strategies for the year, under knowledge and ethics, we hope to create an accessible and updated list of available cannabinoid products that comport with current best evidence and consensus-based guidelines for efficacy and safety. As far as education for practitioners, we want to maintain an updated cannabinoid section of the UMA controlled substances curriculum, and seek additional venues for disseminating knowledge to practitioners. And finally, in pursuit of continuous quality improvement and research, we want to continue to establish and update guidelines and recommendations for practitioners and patients that are based on methodologically sound literature. And that's that. I will pass. Well, I guess we go to the approval of the minutes. Did everyone have a chance to take a look at those?
This is Misty Smith. I vote to approve the minutes.
I'll second that.
Okay, I'm not sure the language that we use to ask for a vote. Maybe Rich, you can. Common sense tells me that it's now time to vote. So maybe raise
All in
our
favor?
hand. All
Yeah,
in
just-
favor. There we go.
Yeah.
And all opposed? I think that was everyone. Okay. I still can't pass it to you, Rich. Although I guess I went out of order. I already did our work plan. So I can pass it to you to talk to us about provider education outreach strategies.
Katie, with regards to the work plan, just want everybody to know the revision of the cannabinoid section of I think it's module 5 for the Utah Medical Association's Controlled Substances Education Program, CME program, is now in their hands. They will review it. They will now distribute it to various the medical organizations they represent, family practice, et cetera, within the state, and review it with their board. And so I suspect at some point we'll hear something about how that's going to be incorporated and updated.
Okay. Thank you, Perry, for putting the work into that. That was needed. We did have the cannabinoid module in there, as Perry said, but it was quite old and quite outdated and very much in need of some updating. So thank you, Perry, for that. That was speedy, and I know that was a lot of work. Any other comments from the board members on the work plan, or hopefully that's something we can kind of sink our teeth into, and I think keep as a living document and guidelines for us to, to adjust as we move forward in this year. We're trying to keep it simple but comprehensive. So please, it belongs to all of you. And
when it's completed, can you share it with the department so that I can post it to the website?
okay, I think Sarah Ponce, you're talking about Perry, the UMA.
Yeah. The
yes.
application. Mhm.
Yeah, that would be great.
Thank you.
I'm assuming, Perry, like you said, it's going to take a little time for them to mull it over.
Yeah, I wasn't able to hear Sarah's, the audio of Sarah's comment didn't come through, but I did, when I spoke with Michelle McComber, who's the executive director of UMA, I did state that the Center for Medical Cannabis was interested in at least having some review potentially of it, to have some input if they felt that was appropriate. It's really the UMA's intellectual property. They asked me to, be part of the editing process, but I did say very specifically that I knew that the Center for Medical Cannabis wanted to be part of the process to the extent they were willing as well. So Rich, you might want to reach out to Michelle and see where they're at. And
Sure.
I want to make sure I'm respecting appropriate boundaries here, because it's, although there's shared material, obviously, and there's shared personnel here. But UMA's business is UMA's business. Our business is our business. We don't want them intruding on us and vice versa. But obviously we're all interested in collaborating, and it's not separate. We're not dealing with separate realities and facts. Their facts are facts and science is science, etc. So enough said.
Yeah, thank you, Perry.
Great.
Okay, Rich.
Yeah. So I think Perry's description there is, I'm going to build on that a little bit, because that's just one of the outreach strategies we have, is to work with some of the medical groups that are out there, like the Utah Medical Association and other groups that can help us do an education of medical providers throughout the state. So some other strategies that we've planned on is we've just recently hired an outreach specialist, Danielle Conlon, and she is helping us. One of the projects she's working on is helping us put together some very simple descriptions of some of the information in the Cannabis Research Review Board's guidelines. Just some summaries of some of the simple messages that are in there about some of the medical conditions and the ways that medical cannabis has been found to be effective in treating a limited number of those based on evidence from federally approved studies. And we wanted to do a better job of sharing that information in a very simple, concise message. And so Lauren Heath, the academic pharmacist that we've brought on to be a consultant for the board and for the Department of Health and Human Services Center for Medical Cannabis, she is helping us draft those along with Danielle and some others. And we'll be sharing those very simple messages that are just shortened versions of some of the information in the longer guideline document. We'll be sending those out to all of the qualified medical providers so they can see some of the most basic points that are highlighted from the guidelines. We feel that that'll, I think, draw increased value and attention to the guidelines that the board has really worked hard on, and not only, you know, put together the guidelines and done a good job of it, but then updated those guidelines, right? And we want to make sure that QMPs and as needed patients and parents use those. And we feel that if we create these very simple messages, you know, 5 bullets or something like that, that give a very, you know, just summarized, outlined with just a few points, that'll just cause more to use the guidelines as a resource. And so that is something that we plan to work on between now and our next meeting in August. And we expect to have at least one of the messages that we're focusing on now is one related to pain management. So we'll make sure that the board has a chance to take a look at that and provide input. We're just getting input from a few parties right now, but we'll expand that to a bigger group later. And again, these are just very simple statements of, you know, 5 or 6 sentences with bullets that focus on just main points from the guidelines. And they are based upon evidence from federally approved studies or from studies from other countries that have the same scientific rigor that the federally approved studies have with IRB approval. So that gives you an idea of one of the efforts that we're going to be engaging in to help get information out regarding the guidelines that the board has worked so hard on. Anything to add to that, Katie, or anybody else?
Yeah, thanks, Rich. So I really want that to sink in. The way I envision this is it's an effort to take what we have stored on the website, the program's website, which you have to, you know, proactively seek out and then go to the various documents and on the different conditions with the recommendations and the comments about the adequacy of the literature to support certain conclusions, et cetera, et cetera. It's our effort to take that out of that stored, somewhat isolated place and put it into people's hands. So the documents themselves are distilled, a product distilled from extensive review of the literature. And as we all know, that took quite a bit of effort. We have Lauren leading the charge there. But that's one level of kind of distillation, and those documents will remain intact and updated as needed, of course. But what Rich is talking about are kind of distillations from the distilled document, is the way I look at it. So, you know, obviously it's a compromise because things will be lost if in our effort to make it simple, readable. You know, I envision an email that you might get among hundreds of others that you're reading through. And if we can include in those bullets some essential elements of knowledge that we want providers to know. And our target right now is providers, not patients.
Right.
I think once we have providers knowledgeable and up to date, or in parallel with our effort to do work on educating providers, there will be efforts to educate the public and patients. You know, that doesn't depend on people proactively seeking out the website and then delving into our quite detailed documents. And they're not just detailed, they're fairly technical. even though they are summaries themselves. So I really want to highlight this and get people's feedback. I know it's a little difficult because you have to try to imagine what we're talking about. So maybe Rich, between now and the next meeting, we can send out some samples.
Yep.
And please comment on that. And we're going to give it the time that it needs. We're discovering that this sounds simple, but it's really not. And it's key to have Lauren's oversight there.
Dr.
So any
Carlson?
comments from the board?
Yeah, Dr. Carlson, is it the idea, or Dr. Obarn, to send something out on a quarterly basis to rank and file providers? Monthly basis, semi-annual?
We haven't set a schedule yet. I think that's a good target, is to send something at least quarterly.
I would agree.
Yeah, and so that's a good suggestion. I like that. And that creates, I think, that helps us also just, I think, budget time as well, because Lauren's time is limited and everybody else's time is limited, but we do want there to be an expected frequency to when QMPs could expect this information. And I would add, we hope it's also a resource not only to QMPs, but to pharmacists that work at the medical cannabis pharmacies as well. So yeah, I think that's a good thought there.
Hey, Rich, I really like this idea, as Catherine said, to disseminate this in a format that's more digestible and a review. I'm thinking about, and also, as Catherine said, to put it in their hands. And one thing I would like to do is to use a resource like that in a grand rounds or something. Not just an email, but some of us have that opportunity. That's one of my roles, is to have a topic and a time and a grand rounds to present. And that this is perfect if it's in a format that's a general review and a digestible format for providers, not just existing QMPs, but those that may be considering it. So
Right. And we know that potentially Intermountain and University of Utah or Mountain Star, that they may have their own resources on this topic as well. Great. We also know that there are studies
or
that
they
are
might not.
done.
Yeah.
Right, maybe not. But also we know that there are a lot of studies that are done by the industry naturally, that the industry has a lot to gain from a patient's use of cannabis, and patients do obviously as well have a lot to gain by a particular company's research that they do internally. But we also know that at times some of those studies that are done that don't have federal approval, some of them are high quality, but others aren't as high of quality. And that's just the nature that we find ourselves in right now with cannabis still being federally illegal. But despite that, we know that there are still some evidence that is of scientific rigor that are federally approved or done by another country that are still valuable to share and that have scientific rigor to them, that are methodologically sound studies. And we have a role in ensuring that providers are aware of those, and that the pharmacies are aware of those if they're not already aware.
Rich,
Now,
Rich, just a quick comment about that. Wouldn't it be a true statement that a study would not be a quality study if it did not at least pass through the basic framework of an institutional review board, the purpose of which is to assure patient rights, that the ethical bioethics practices are followed rigorously in order to prevent undue coercion, taking advantage of patients,
sure.
Kinds of things that create faulty methodology and lead to false conclusions. So how can we make a statement that says there are quality studies that do not go through that process. Wasn't that the intention of the legislature in
Mhm.
their language and their mandate to us as an advisory board, that's the sort of the foundation for the kind of program that we would have as a medical program in the state.
Yep, good point, Perry. And Dr. Carlson and I have talked about how our standard in the statute set by the legislature goes beyond even RRB, right? It states that it must be a study conducted or approved by an IRB, approved by an IRB, and that was conducted or approved by the federal government, or if it's done in another country, that it demonstrates, as determined by the board, a sufficient level of scientific reliability and significance to merit the board's review. So those are the standards set by the legislature. And so we know that there's still those studies that are approved by IRBs that may not be conclusive or may not be clinically relevant because the IRB is looking out, of course, for patients, as we all know, and patients' rights. It's not necessarily a guarantee that the study is clinically relevant. And there's some real value in the studies that cost a lot of money, but that are double blind, that are randomized, where there's a placebo-controlled trial, and that is the gold standard. That is the best case, obviously, but there's different types of studies, obviously, and we just want to ensure that the board and also the public and the industry are aware of the board's mandate to keep their review of studies to that standard of that I just described, that's placed in the statute. Also, we acknowledge that companies do their own research, and they're welcome to continue to do that. But we are still in this challenging period of there not being a high volume of federally approved studies. And so naturally, some companies, they'll continue to do their own. And they're welcome to do those and share those with their people. But what we are focusing on at the Department of Health and Human Services and the Cannabis Research Review Board is those that have been approved by the federal government. And people can certainly contact lawmakers if they choose to maybe create a separate board or something that evaluates those studies that are not approved by the federal government. And the quality of those is some of which are high and some of which are low.
Well, Rich, I mean, that's kind of like the Journal of Unreproducible, events. Or something. I mean, that's,
Sure.
I think I'm trying to follow what you're saying here.
Mhm.
And maybe you could make it, for the sake of the board and others on the call and meeting here, maybe comment, and Katie, Dr. Carlson as well, efforts that you have made to glean and gather that information, as well as myself, obviously, and have come up empty-handed. So even though people talk about endlessly in some meetings we've been at, all this material and all these studies and all this proof of this and that and the other thing, I've certainly made efforts. I know Dr. Carlson has, communicated some of those efforts as well. And Rich, I know you've made a lot of efforts to gather those quote studies, and so it allow transparency in, as well as, if you will, truth in advertising, to be honest and have some integrity. So people are saying what they mean and mean what they say. And yet as far as I know, we have received virtually nothing, and the occasional things that have been sent when they've been evaluated, the basic screen for methodological soundness, for integrity, for patients' rights being respected, the kind of basic principles of both science and ethics, they don't begin to meet that mark. So I'm not sure where that conversation is really going, Rich, but maybe you can be a little.
Well, we just extend our invitation to people that are out there that feel that there are some studies that are federally approved that we're not evaluating. Please share them. If there are studies that are not federally approved, then those aren't within the scope of the board, the board's evaluation. And so really the board members are experts in evaluating those that are federally approved studies and that have gone through an IRB. Now, I want to emphasize that the department and the board, they aren't discounting the anecdotal cases that are happening in Utah and throughout the world of patients finding great benefit from using medical cannabis and treating conditions where there's little or no evidence. We acknowledge those cases exist, right? And there's some great stories that people have had of being able to treat their conditions with something, an alternative medication like medical cannabis. So, but the purpose of the board is not to evaluate those cases. The purpose of the board is to evaluate the federally approved studies that we want to ensure are shared with also the industry and with providers and pharmacists throughout the state. So,
Yeah, I think this is this is a really good discussion that I think this concept of a email blast, for lack of a better term, can help solidify as we work on those, because I see this as our effort to participate in the discussion out there, that to be part of the knowledge base that people are referencing when trying to make decisions for their patients, when providers are trying to make sense of what might be an effective treatment for a particular condition and a particular patient, and how to set up that individual treatment plan. I think right now, this is my sense, is the information that we have come up with based on extensive review of the scientific literature is somewhat removed and less accessible than some of the other studies that might be floating out there and promoted in different ways. And I would like us to promote what we've done. And it just occurred to me that maybe as part of this email blast with each one, we have an intro that describes what our process is, describing the integrity of our process and how it's applied in each of our reviews of the qualifying conditions.
sure.
And explaining that we do review studies, and that first pass, as Perry described, is determining whether it's scientifically rigorous, methodologically sound, and ethical. And then after that, we can break it down and then create this body of knowledge that we would like to disseminate. So that's how I look at this. It's our effort to participate out there.
Great.
And other comments from other members?
This is Brian Zender. As a practicing physician and provider and a QMP, I would think that for those in the trenches, it would be helpful for them to know which of the following conditions that are approved are actually scientifically validated and which are not. And that would be helpful for some providers who really try to stay closer to the science than to the politics.
Brian, I think that's a great idea. I mean, I think, you know, really what we're trying to introduce is this concept of taking what we know and disseminating it. And that's one of the things we know, what you just said. So I don't think we have to limit it to specific recommendations about particular qualifying conditions. It can include an email blast describing just what you said. And in fact, I think we should. So again, if we think about this as an effort to take what we know and put it in the hands of physicians and providers trying to treat patients safely and ethically.
Right. And then following up with some of those professional groups like the Utah Medical Association and some of the other, you know, the Audit and Surgical Medical Society and the PAs and the EPRNs, you know, let's make sure we partner with them in disseminating the information and that we follow up and be a resource as well. So, and also to the Utah Cannabis Association, to the Utah Cannabis Co-op, to these groups that have members who are QMPs and also pharmacists that are participating in Utah's program. We want to make sure that it's a resource to them, although we know they have other resources, that this can be a resource as well.
Well, and I would add to that, seeing that Ms. Denquist is on part of the call, that, you know, for advocacy groups, you know, there's sometimes a fine line between commercial interest and advocacy groups, and I'm not sure always, you know, where that line is. But for those who are truly advocating for the best interest in the health, public health, and individual health, and want to make sure that folks are getting good information and not misinformation or information that might be harmful one way or the other, we want to be able to provide that information as well. Right now, there seems to be a big divide, and I don't think it's, I don't know if you call it politics or whatever, Brian, but I sort of sense what you're saying here, because there seems to be a little bit of a I don't know, polarization here between those who are trying to get just, you know, objective information out there, evidence-based information, unfettered by politics or by opinion, but just what we know versus what we don't know, based upon basic scientific method, versus those with a commercial interest and with an agenda. And the agenda is to move product along, and sometimes behind that agenda is the pertinence of, you know, advocating for patients and the public and so forth, but it's really about commercial interests and financial benefit. And I think that the plan that Dr. Carlson is talking about, and you, Rich, is to try and neutralize all that, right? Is to look, let's just try and get good information out there, and then that people can then decide what they believe is in their best interest.
Right. And I think we can find that some of the companies that are in Utah's program, that their goals align with ours, and that there are providers and pharmacists whose goals align with those of the department and with those of the board. And I'm excited to build on the relationships we have to ensure that there's some very simple messages that are shared that are based upon research that the board has done. I think we can make it work. So I think that's all for outreach strategies. We've got a lot more detail that we'll be working on here in the next month or so, as we've hired an employee to help us build on some plans that we've wanted to take action on for quite some time. So thank you for providing some input to the Department of Health and Human Services, Center for Medical Cannabis, as we make some plans for those strategies. So
Okay.
that's all for item 4.
Okay, so moving on to the chronic cancer pain guidance language approval. That document was sent around after Lauren made some additions to, I believe it was Dr. Odell. Was I might have gotten that wrong. We sent the document around with some adjustments. I think they were in red. So at this point, Rich, are we looking for approval of those further input? How does this go?
Yeah, if the board's ready, Sarah, do you have that ready to present? Sarah Lelos? Great. Yeah, so this is the document that had been created, and I guess we are seeking the board's approval of what is being presented now.
Yeah, so if those of you who read it, if you have any kind of final corrections or edits, now would be the time, and then we move to approve. Is that we need a motion to approve?
A motion to approve and then a vote.
Could you just quickly highlight the changes? I know this has been circulated, and Dr. Smith, Misty Smith, had actually reviewed this and had been, I think, the only person who had some specific recommendations for revision based upon including a little bit more information about some of the studies, as well as the conclusions of those studies. So Misty, I know I'm sort of crossing over because some of this was left over from the previous term, if you will. But Misty, did this meet with your satisfaction in terms of some of the concerns you had? I think everybody else had signaled that they were satisfied, and I just want to make sure, Misty, since you were the most, you'd taken a specific interest in this.
Yes, thank
Yeah.
you. It did. Thanks.
Yeah, I think one of the things we could highlight, I'm seeing now the document that was circulated had some of the additions in red. This obviously doesn't. One of the pieces that Lauren worked on was creating a section to comment on the limitations of the studies, kind of add a little more flesh to that. I believe that was the most significant edit that was made. And I'm not sure, Lauren, I think I suggested that maybe go, I think I defer to you, does that go at the end, commenting on the limitations in general of the 3 studies, or after each study? I'm not sure what you went with, but Perry, I believe that's where some of the work was done in the recent weeks.
Yeah, and I think that I'm now trying to put this together with our previous conversation, and I think that the approach we've taken in creating these documents that then go into the portal that that we've created so far, the website, is it does 2 things. One is it creates sort of bottom line findings and sort of recommendations, and the other is the detail, how we arrived at it. And there are some people who are going to be very intensely interested in the detail and the science and what the studies show, and keep that and maybe create a library of that for their own use, who have a lot of interest in this. Others are just going to simply say, what's the bottom line? I mean, it's kind of like, let's take another example, like baby aspirin. Who should be taking baby aspirin every night and who shouldn't? If you have are in a category of individual who might have benefit from it, what are the risks and how do you manage the risks? as a family physician or another type, what's the bottom line? How do I make recommendations for these patients? And there's a huge amount of literature behind all that, but I don't have time, interest and so forth. But if you're involved in that particular area of cardiovascular research, gastroenterology, whatever, where there may be, you might want that. So if we create these documents, and I think we've done a very good job of that now, and I think Lauren is in following that pattern. I think this is really very helpful because people can go right to the bottom line, but they can also access the other information. I think our obligation is to do both, but what we send out for instance on a quarterly basis could be that, copied and pasted, if you will, the bottom line stuff, and then let people know how, if they're interested in how we arrived at that, how to find it. Go right to the website. So create a hot link to that. So that seems like a good bridge between these two things. And I know that covering a lot of territory here in that discussion, but with the cancer pain, this is sort of our first effort at doing that. Well, I think also the acute pain one that Lauren had presented last month is a good example of how we can also do that and use that method.
Yeah, I like that terminology, Perry. That really speaks to me. What's the bottom line? It's almost like I'm not going to read the whole study. I'm going to read the abstract. Some version of here's really what you need to know about cannabis and acute pain.
Yep.
And I think what you're saying is to maybe add that bottom line into these documents.
Mhm.
And that wording will come from us working on what this kind of email blast bottom line is, and having a link to the more detailed, expansive document in every email blast is a must.
Yep. So we have an executive summary and then it links.
Yes. Yeah. So Perry or others, Misty, other comments on this document for cancer pain and nausea associated with cancer?
I guess I just had some more comments kind of on that same line, that we could have a kind of growing list or a table of, condition, and then some of what we already have from the first line of some of these paragraphs, insufficient evidence for neuropathic pain, boom, and then links to our full document. And if you were quickly looking through all of our approved conditions, then you could click and find, here is the whole background document, and here's the one line, strong evidence for nausea, vomiting, limited evidence for this, no evidence to support for that. And at a glance, you can see kind of where we're at least as a board, as far as making recommendations on the literature. And I don't know that any of that has to go into this, though. I see that we have like disclaimers and abouts for the first 3 pages before you ever get to any actual information about anything, which can hamper people deciding to read anything. It could be nice to have a little plain language at the top, but that could also be like a separate section that lives outside of the document that goes on the website or something.
Yeah, the lawyers, Mike, they get their hand in this before.
Like, can it go at the end? Can it go at the end?
If that's actually not, I mean, we should look at that, all of us, is there a way to have a disclaimer link? The disclaimer applies to all of these things. We discovered, years ago that we were trying to make recommendations on very specifics, like how to dose. And yet it was based on a lot of supposition and insufficient evidence. And so we wanted to make that clear. So we don't want to lose the disclaimer, and I think, to be honest, Perry, you're right. It was kind of a legal lawyer thing. If there were adverse outcomes from people being treated for a condition, could it come back to Department of Health or we wanted to make clear that we are making our best effort to guide people in terms of dosing and recommendations. But let's keep in mind, this body of literature is growing, and as of yet, there are many holes in it. So Mike, I think this is a really good point for us to to act on. It could come by putting it at the end. It could
Yeah.
be a link. It could, I mean, I think there are many ways we could, you know, make it visually more usable. And then, you know, I think, again, it's such a strength of ours to have Brian and Matt, who are out there treating patients, who can bring back to us, here's what we need. We need a blast on this. So I don't think we really right now know exactly what we don't need to necessarily limit what we're putting out there in these quarterly or whatever blasts. I think we're really, it's a concept that we're trying to build on. So so I think that that feedback from Mike needs to be acted on. That's a very good point.
So if it is the recommendation of the board that we take the guidelines, the long document, in each of those long documents, that we take the disclaimers and legal information at the beginning and we cut and paste those to the end, is that something that the majority of the board requests that we do? And we can consult with our attorneys about it, but with the board's support, if the attorneys don't have a significant concern, then we can just make that change.
You have my support.
Okay.
Yeah, I agree. And you know, I like your actually the language that you used, Rich. I think if the lead sentence is the executive summary,
Mhm.
meaning that sounds sort of administrative, but you know, key findings
Right.
or clinical
Right.
for those of us who actually, I don't play a lawyer on TV, and I'm not one, but I actually do practice medicine and treat patients, and I am a QMP, and I would find, you know, all this equally valuable as Matt and Mike and Brian and you, Katie, treat patients, you know, to start with key findings, and then all the rest of the, you know, we've got to have the legalese in there, but maybe that can be at the end, but the methodology and how we arrived at that can be second for those who want to go to the next level.
Sure.
Yeah.
Something like,
Yeah. And I mean, I'm in favor of considering some informal language for that. I agree. Executive summary sounds non-usable to providers. And yeah, I get asked all the time, you know, what about this? How do I manage this? What are the risks in using cannabis here? And, you know, I think of it, what do I need to know in this area? You know, so, you know, we could come up with some language that is user friendly also, you know, bottom line, what you need to know, key facts. So all of that is on the table, and needs all of our input there.
Okay. So just some actionable items that I can take back, that Sarah Ponce and I can take back to staff and work with Lauren Heath on as our consultant, is just taking action on what you've described as a preference from the board that we create an executive summary of each of the medical conditions, and that we create that language as a draft, what those executive summaries would look like, and that we place some of the legalese at the bottom of the document opposed at the top, and we put at the top the executive summary. And then it'll take time to do all of this because we want to make sure we take the messages that are most critical and put them in the executive summary, and it will just take time to make sure we choose the right language and do it in the right way as a state agency and as a board. But we can begin that process. We've already started to take a look at the pain management one, and we'll just, as we get that language for each of the executive summaries, we'll share it with the board, and you're welcome to provide your input, and then we can then take action on actually executing a messaging campaign to QMPs and to the industry about what we put together.
Yeah,
Great.
I like that. And I think you're right, Rich, like we talked about before, this is going to take time for Lauren and the outreach specialists. That's the purpose of her time. But, you know, that wasn't necessarily Lauren's original purpose. And so
Right.
this is going to add time. And I think, you know, this first one, especially if I think it should be pain, you know, that's the top of everyone's list in terms of what's, you know, the condition that patients have that they most frequently are seeking advice on or treatment for. So I, you know, once we send it out to the public, we can't update, or I mean, we can update, but we can't retract it. So we need to put the time in. We really do need to have our
Yes.
board members' eyes on it and bring their expertise to it and take the time that it needs. And I think once we get our kind of feet on the ground with this, the next topics might be a little bit easier. But I think this first one is critical.
For sure. Great. I think it might be good to take a vote on the cancer document changes. Or the cancer document in general, I think needs to be voted on.
Yeah, we haven't gotten to that yet. So
Yeah.
we need a motion.
I so move, Ms. Misty Smith. To take a vote.
I'll second that.
Okay, all in favor?
Aye.
Okay, I think that was everyone. Okay. So that's approved.
Great. Sarah Lalos, would you just post the agenda? Yeah, great. Dr. Carlson, looks like it's just an opportunity for me to just share a few updates.
Yeah, and I'm assuming this will, you'll touch on yesterday's governance structure meeting.
Yes.
Okay.
Yep,
great.
happy
Thanks.
to do that. Yeah, so yesterday, by way of just providing an update about operations of the Center for Medical Cannabis and some things that the legislature has been evaluating, is that yesterday there was a public meeting of the Medical Cannabis Governance Structure Work Group. And this is a work group comprised of members of the legislature, both the Senate and the House. Members have selected specific lawmakers like Senator Vickers and Representative Ward and Senator Davis and a few others have joined on this committee, Representative Daley, Provo, and they are wanting to evaluate the state's current medical cannabis governance structure. And there was a meeting that was held last month where they got input about potential changes and the program from the Department of Health and Human Services and also the Department of Agriculture and Food. And yesterday was the opportunity for the Utah Cannabis Association and the Utah Cannabis Co-op and the Utah Patients Coalition and also Truce, represented by Christine Stenquist. And also a few others were able to share their thoughts about medical cannabis governance structure and what changes, if any, would be helpful to patients and would be helpful to ensure that the public is healthy and safe as medical cannabis is grown and processed and sold in the state of Utah to qualifying patients. So some of the topics that came up during that meeting that the board may be interested in is there was some discussion by some presenters regarding the Cannabis Research Review Board, this board. And one presenter commented that the Cannabis Research Review Board found no evidence that medical cannabis was effective for treatment for epilepsy. We know that that is not the case. Although that was presented, that is not the case. The board, as we all know, we have a guidance document that cites multiple studies. And in fact, it's in the Cannabis Research Review Board suggested guidelines that there's some dosing guidance in those guidelines for treatment of epilepsy in adults. And that dosing guidance is based on clinical trials using pure CBD like Epidiolex. And so there's some studies that are cited that are federally approved that the board felt comfortable with. So that was one comment that came up that was something that we wanted to just take this opportunity to respond to. Also, another concern that was expressed is that the Cannabis Research Review Board does not consider some studies that suggest medical cannabis as an effective treatment for some medical conditions. And one in response to that concern that was expressed, we believe it's important to consider that while IRB approval is important, and that is one of the standards that are required for the board's review of a study, that is not the only standard. And just because a study has IRB approval does not mean that the study was conclusive or clinically relevant or unbiased. It ensures protections to patients, which is very important, but it's possible for an IRB to approve a study that is not methodologically sound. So I think it's important that the public understand, the industry understand that the board is required to ensure that the studies that it evaluates are IRB approved, but also that they're federally approved. And then those that are not federally approved, if they're from another country, there's still some really great research from Israel and from Canada and other countries. We just ensure that those studies that are done have the same scientific rigor that others may not have.
Can I ask,
Anyway,
do we have any section in these guidance documents that say we did X search strategy and these were our inclusion criteria, and the studies we did not include because they failed to meet criteria 1, 2, 3 are these, and there's like a supplement or something like that, kind of like a standard thing that might be in a systematic review that we would find otherwise?
No, that the details of our search are not listed in those documents.
Sarah, can you say that again? That there's your mic is a little bit fuzzy.
We do not list that information in our guidance documents.
Right. Yeah. What we do in our guidance documents is we just focus on the literature that was evaluated as having the scientific rigor and that are federally approved. And I suppose that the mandate from the legislature and the statute does specifically say it has to be federally approved, or it has to, if it's conducted by another country, that it demonstrates, as determined by the board, a sufficient level of scientific reliability and significance to merit the board's review. So, but Dr. Moss, it sounds like your idea would be to maybe change. I think it would require potential change to the law to expand the board's evaluation to studies that go beyond the federally approved, or
I mean, I guess this would be saying presumably we're looking at a study and we have to then look at its background and its methods to determine whether it qualifies. And that enough, we could say that as part of the mandate that we have by the legislation, this study didn't merit further evaluation for inclusion. So I'm not seeing that it would require a change. We're just acknowledging why did some studies get evaluated or not. And it's simply that we looked for studies that met these criteria and these didn't. So here they are, and here's the criteria they didn't meet and why we couldn't use them.
Mike, just, having been through this for the last, I guess since inception, when we started doing this, to a certain extent, our ability to go to those depths have been limited by resources. But just to sort of let you know what we've done, Mike, is essentially search the literature through the usual databases.
Exactly.
And that then includes PubMed and others similar where basically peer-reviewed journals are publishing this material and do include that information. Their ethics require them to disclose whether there's IRB approval, whether in fact there's been federal funding and approval. For instance, anybody who, like myself, who's been a researcher in this area, I've got a DEA-1 registration, otherwise I can't even access the material, and so forth and so on. So, it's a little bit of a tautology, right? A journal publishes an article because it's already gone through that peer review process. Now we're trusting that process, and there are plenty of examples where there's been some corruption in that. The one thing we don't have access to is the so-called literature that's either not peer reviewed, does not appear in any database, does not pass through any type of is privately published. And as you know, Mike, industry, drug companies, they do all sorts of studies, most of which are not published, either because they don't serve their purposes, or they don't end up passing muster for that kind of level of integrity. And
yeah, that's understandable. Like, we can't find what we can't find, right? And therefore it's hard to say what did we not find that was not findable. And I understand that is, potentially an infinite number of things that we can't list out there or whatever else. But as long as people are understanding, or that's very clear at the top that these are the studies that were included. And if someone brings up, well, you didn't include study whatever from this company, like, well, it doesn't meet criteria. Or if there's a very easy way to refute these sort of claims of us not including literature that someone believes supports.
Well, at the very minimal, Mike, what we can do now, especially with Lauren at the being involved in this process, is we can at least list the databases and the search elements, how we got to, because there's a lot of stuff online, right? But that online stuff, they say, they might call it a study, they might call it research. It's not, and we're not going to include that because we can't go through this universe of material that's out there. But we can certainly go through and list what we do pursue and have some integrity there. I think that's a good.
That's exactly what I would like, as a separate document, a lead document, which describes our methods, the criteria for inclusion, the databases we search.
Great.
Basically Lauren could describe what she does and how she does it. Going back to years ago when we were creating each document, someone other than myself could describe what methods we use, including the databases that Perry mentioned. I think that's essential. And I also think that's essential to put that should be one of the pieces of information that we disseminate to the public. Because right now what's out there is, we just willy-nilly reject these studies because we have a personal bias or for some reason. That's the explanation that's out there now. And it doesn't relate at all to what we've been doing and how we've been operating. And I think that that's essential, that we get that in our website in a separate document, and we then make an effort to disseminate that to the public.
We'll make note of that and then share it with the board once that's been drafted. That's a great idea.
And
Yeah.
then I would add, and Mike, when, just looking at this pain document, we do explain in detail, why we might come to a conclusion of insufficient evidence or inadequate. I think that's a different matter than what passes that first level of review. But once the studies do meet that peer-reviewed, standard, then we go through with a fine-tooth comb to look at what the limitations might have been. Were primary outcomes achieved, or were only secondary outcomes achieved? So I think that's pretty clear in each document. Maybe, Mike, you could take a look. You have kind of new eyes on this, fresh eyes, and see what you think. But I think that process should be described in our overall process as well, not just what kind of made the grade for that first pass, but what we do and how we do when we are looking at the body of literature that did make that first pass.
Yeah, no, I agree. I don't see that we have missed anything. It's just what way can we explain it to people? And this is the basic stuff of any method section of a review paper, right? If we searched PubMed, Embase, whatever else from X years with the following search terms, and this is what we came up with, you could go reproduce the same search right now and get the same results. And then we use the following criteria to include studies. We found 1,000 articles, and then we narrowed it down to 5 is that we could actually review. Here they are. And that's 2 sentences at the beginning of, in whatever method section. It doesn't have to be a whole piece. And I guess if we're using consistent standards of grading evidence of there are, high quality randomized control trials and systematic reviews versus, observational data or animal data. And then our level of evidence supporting that is, whatever system we use of 1A, B, C, D, whatever. And then it's just a consistent thing that we decide of all of the things that are out there in the evidence-based medicine world to kind of pick from and say, boom, we apply this standard. This is how we operate. Like I said, it doesn't have to be, we're not reinventing anything here.
Right.
Just telling people what we're doing.
Just
Mike,
documenting what we're doing.
just by way of going back to how we got to where we are, we really did have very high aspirations of using the grade methodology, which I'm sure you're familiar with, and other standardized approaches to grading quality of and qualifying levels of evidence and so forth. As it turns out, those high hopes we had, and we actually listed those in our methodology that we reported back to the legislature with, that this was what we were going to do. It turns out there simply were not enough research studies that qualified to be even graded. There were a few meta-analyses that allowed us to do that under certain cases. But the level of detail that you're now describing is what we would hope to do. There simply wasn't the material out there to be able to do it. Over the course of time, it would be lovely if we really could. But we're sort of dealing with, we're sort of going on stage with the band we've got rather than one we would hope to have.
Oh yeah, no, I don't mean to say
no, but I just wanted to let you know
wrong at any point. Yeah.
No, I just want to let you know where we.
But toxicology world, we don't have any rigorous studies. All of our stuff is based on case reports and animal data. So I understand the world of there is no literature in the world to do this from a rigorous standpoint. So we have to use our expert opinion and the very basic sort of information out there. So fully appreciate the lack of evidence and trying to operate on that.
Yeah, we did give it our best shot and we didn't quite get there. But
well, I think this speaks to kind of our working strategies. This is an ongoing process. There still is the hope that further research is or will be conducted that helps to solidify some of the areas that we decided were, inadequate evidence or I forget the terms, inadequate, insufficient, not sound evidence. So I think that fits with our desire to, continuous quality improvement in research.
Yeah,
Um,
Kathleen, can I add to that? I think that would be an area of possibly some diplomacy where you could say, like you said, this is an area that's suggested by these poor quality studies, but is required, more research, high quality research is required. If you added something like that, that would add an element of diplomacy to say, we recognize that this is very suggestive, but we need this kind of a study and we need this.
Yeah, that's describing it for exactly what it is, Matt. I think that's what this discussion is about. How we were kind of in our kind of science medical research bubble years ago when we had to pore through what was out there, trying to really make sense of it for ourselves and each other, so that we could take it to the legislature. Fast forward to now, we're kind of up against this concept that there are some notions about our motives that we didn't necessarily anticipate that distort the purity of what we were going for, and we can't cling to that. I think it's now about how do we participate in the discussion of facts so that in a diplomatic, usable way to kind of counteract some of the misinformation that's out there, or the information that's based on biased studies. And so I think that's exactly what Matt said is really exactly what we're trying to do right now. And maybe that falls in the education for practitioners and the general public effort. These blasts. And I also just want to say I'm hearing in some of this discussion mountains of work for this volunteer board potentially. What I'm having, my fingers are getting tingly thinking that we have to go back to each document and rewrite it and relook at that. And maybe over time we could do that, but I would propose that we consider a way to come up with some statement that's maybe general and applies to all of the conditions, that's honest about what it is. This is in reflecting back on all of these documents. We wish to make a better effort to explain what the methods were, as opposed to going into each document, epilepsy, chronic pain, PTSD, and then coming up with a specific thing. That could be something we work on, and if time allows. But I just want to remind everyone, when we talk about some of these things, there's, a massive mountain of work that we could do. And then there's the realistic work that can be done starting now, given the resources that we have. So,
with that, Katie, just, in Matt's cry for diplomacy here, which I really resonates with me. I think one of the things we could do, Rich, to that end, without reinventing the wheel or starting all, and the good news is, I don't think we have to do it because there's not a whole lot of new stuff that's out there. The bad news is there's not a lot of new stuff out there. I mean, we wish there was. But Rich, why don't we do this in a very public, external, front-facing way? Let anybody who's interested, any and all stakeholders, know that the Cannabis Research Review Board is here to review literature, to review evidence. Anybody who has a study that's in a published form of any sort we will receive that information. We will review it. If they believe that it qualifies under the mandate that we have in terms of those basic qualifiers, stay what they are, as you've done, Rich, send them in, and we will report back on a monthly basis just as on our website, a form of communication, what we have received. We can be anonymized. Nobody has to be embarrassed by anything, but what studies have been received and what state of review they are under. And, they've been reviewed and this is the decision based on what, so that we're completely transparent about this. And we can't be accused of neglecting things or of filtering or being biased when I don't believe we are or have ever been. But also it keeps a level of integrity and honesty on both sides, meaning, if people say and make statements about there's all this evidence and studies being done, and they don't, disclose it or make it, then where's their accountability? So let's make this a two-way street, very open, very public, and let's create this repository where we can review this stuff and then very publicly state why we're making decisions we're making. Is that doable?
I can't answer if it's doable in terms of
Rich, you were
resources
muted there.
on department. Okay, go ahead, Rich.
Oh, I was just going to say, we can send out that notice to stakeholders, absolutely, and remind them that we seek any studies for sure. Yep, that's no problem. That's easy to do.
And what I wanted to add to, or maybe just, we need to keep in mind that the horse is out of the barn a little bit. We have already been determined to be irrelevant. I want to say that there are parties that have decided that we are irrelevant. And I think, again, that goes back to kind of the structures that we were, the confines of what our initial strategies were. Get documents that could be thrown up on our website. And that took a lot of work, a lot of research, reviewing went into that, and discussion, and individuals coming and making presentations to the board. But what I think we need to do, in addition to what Perry is saying and what we're doing, there's an open invitation. There have been folders created on the website for people to deposit studies in that they want us to review. I think we also need to understand that we are getting bypassed. It's not like everyone lines up to, ask us to look at some information before they send it out to the public or the providers or put it in their promotionals. Does that make sense? That they're bypassing us. I understand why, everyone's got their reasons. And so we, again, need to build direct lines of communication to Vickers and the legislators that are trying to make sense of this. We need to build direct bridges to recommending providers. And ultimately, we need to build direct bridges to patients and the public.
And we'll do that, but I will acknowledge that there are a number of providers and businesses in the medical cannabis space in Utah who they fully acknowledge that the studies that they are evaluating are not federally approved, but they still evaluate them and they make decisions based upon them. Or rather than basing their decisions on studies that aren't federally approved, some of them make their decisions based upon the patient's feedback, right? A certain amount of that, I'm not a practitioner, obviously, but a certain amount of that happens in the FDA approved drug world, right? Where you listen to a patient, they tell you, hey, this is what I'm experiencing. Okay, let's change this dose, right? The pharmacists at every medical cannabis pharmacy have those discussions with their patients. And the pharmacists are careful about what they say, but they listen based on their knowledge. They listen to what the patient is saying and give this patient the best guidelines they can. And sometimes those guidelines aren't based on a federally approved study. It's based upon just anecdotal information. They had heard that some other patient had found success in using this. They read some book where it shared some stories about these patients. I cannot speak for the industry, but I'm just saying this is reality. My understanding is that's quite common. And the law allows for that to happen in the state of Utah. So there's there is not a requirement that every single patient receive their medical cannabis based upon federally approved studies, right? But the role of the board is to ensure that those providers are aware of that research, so they can rely on that, along with listening to the patient, along with some of these studies that are not federally approved, but still have some helpful information. Some of the studies that aren't federally approved aren't of the scientific rigor that those that are federally approved are. That's true. But the reality is that we do have a law that was not written upon federally approved studies. It allows for this large group of people to get access despite what the studies say, or the absence of studies, right? So I feel that the board has a role in continuing and to expand on messaging about what the federally approved studies say. And we got to expand on that, right? We have a lot of room for expansion on that, and we will expand on that with help from staff on our side. So I just wanted to make sure we acknowledge of what reality is out there in the industry in Utah and other states today.
I just wanted to say that I want to acknowledge, I had called out Ms. Stenquist's name earlier, and her hand's been up. As we're moving towards the public comment section, I really do, I very much want to hear what she as a leading patient advocate has to say about the commentary and discussion and the education and the role of this board in summarizing what evidence exists. We know that the evidence that absence of evidence is not evidence of absence, but the way medicine is practiced is based upon scientific method and evidentiary foundation. And a lot of what happens in medicine does not have strong scientific foundations because we don't either understand the science and the processes of disease, or we just haven't gotten there and so forth. And we're always trying to find this middle ground, but there's always a rationale and a basis for clinical decision making that we're held accountable for. And those processes are quite rigorous, and there's a lot of discipline in them. And we just want to assure that, and I think the legislature has asked us to be, in a sense, sort of referees for that. And then decisions can be made by an informed public. And so I know that Ms. Stenquist has had her hand up for a while, and I see Dr. Viner. I'm not the referee here for that either, but I think that we've got plenty of time here. And Katie, I don't know where you stand with this, but I think from a patient advocacy standpoint, people who are not scientists, they're not clinicians, but they really are interested in their health, in if there is therapeutic benefit, and they understand the balance between benefits and harms, where all that stands. That's important information. I'm just concerned from the standpoint of what the legislature and our legislators are hearing and being pounded with and lobbied for, that the public and individual health interests may in fact may not be top line. It may be business, profit, finance, money, influence, power, taking over businesses, etc., that have nothing what to do with public health versus access for health related interests. So anyway,
I think I listened to the presentation by Truce yesterday. They provided a detailed, comprehensive presentation, and I can't recall all the details, but I did hear in there, what I filtered in is their desire to have more information about the content of products and labeling that can really inform a patient and their provider. And so yeah, I think it's really important that we hear from patient groups, and like you said, that's how medicine is practiced. There's the literature to inform decisions. And then there's the individual patient and the context of that patient that, and you know, that's one of the things this program is, and I'm not talking about the board here, but the program in general, you know, trying to play catch up on is how do we get objective feedback from the impact of our program. And that's a mountainous task right there, but that's an essential part of all clinical decision making. You know, we could come up with endless examples, you know, about estrogen replacement and how, you know, there were scientific conclusions and then impact on populations that adjusted the scientific conclusion. So I think that's really important, Perry. Before we do that, I want to make sure that every board member has a chance to weigh in on this last discussion that we're having, or anything that's on the agenda. Please now, I'd like to give the board members a chance to weigh in or share any comments that they have. And anyone from the Department of Health, Sarah or Lauren, please, any information that you feel we should have before we head to public comment.
I have a question for Rich. Rich, you mentioned, and Katie, that there was some frank misinformation that was provided to legislators yesterday at the meeting. What's the means by which misinformation can be corrected or refuted, and legislators can get a clearer sense of what's going on, rather than very strong, I guess, opinions that are meant to influence them in one way or another?
Yeah, so I just have direct conversations with them, like yesterday after the meeting. And also I have meetings with them during the summer and exchange of emails to ensure they're aware of the purpose of the board and what the board is doing. That's something that we do, and I can, as we have additional documents, I'm going to make sure that they receive copies of those in the future. And so it's just direct communication, Perry, to remind them. And some of them are already aware of some of those things. But, you know, I would say there was some information that just, I think maybe for sake of brevity or whatever, it just was incomplete. So, for example, there was discussion about how every patient has to get a QMP, right? And that's and how that creates a barrier to access because there's only so many QMPs. But no one mentioned how there is a limited medical provider program where 21,000 prescribers across the state, MDs, DOs, APRNs, PAs, podiatrists, any of them, if they choose, can choose to recommend up to 15 patients, right? So that was, I feel, just a little bit of information that was incomplete. And so we want to make sure that we do a better job of communicating information about that program so providers know and patients know that their regular provider who they meet with, who they have a close relationship with, if that provider chooses to recommend medical cannabis, that provider can indeed do it without having to pay a fee. We would hope they would do it with having some basic knowledge about medical cannabis, but that they have that ability to make a recommendation if they choose to. So there's just information where I feel it was just a little incomplete. And we fill those gaps by communicating with lawmakers and then also just assessing our future plans to communicate information and building a staff that can communicate very simple messages that help us educate the public and also providers in the industry about parts of the program that maybe are missing from some of the knowledge out there.
And there were some incorrect statements made about our methods.
Oh, sure, about the Cannabis Research Review Board, and we brought those up already.
Yeah.
And I feel, Perry, and also Dr. Carlson, that we can and we will ensure that lawmakers and industry is aware of the scope and the ideas that you've communicated were great ideas we're going to take action on to make sure we define, hey, this is the process that the board goes through. We have an academic pharmacist that does A, B, and C as they evaluate and sift through the studies that are out there. And the law indeed does require that the 100% of the studies be federally approved, or that they're from another country, that they meet that same scientific rigor, right? So that is the reality. And sometimes there's a mixed message that comes up in a meeting like yesterday where it makes it sound like something else. So we will ensure that message is shared, and I can report back to the board and let the group know how that goes.
And I think there was discussion in earlier meetings about committee meetings with Vickers, and maybe you can give us information on that.
Yeah. Yeah, so we are meeting with key lawmakers that includes those that were part of the meeting yesterday, and those some of which weren't there yesterday. And those meetings are happening, and we have topics that they ask us about, and we give them updates on. One of those topics is our software, and we have taken some specific steps to make improvements to our software and to work with our software vendor on specific performance metrics that our contract requires that they meet. And so that's been a recent topic that we've discussed with them, but also we do have discussions with them about the Cannabis Research Review Board and the work that you do. And we will continue to give them an update as part of our agenda about the work that the board is doing, and I'll include topics that have come up during this meeting in our next meeting with those key lawmakers.
Yeah, that's great. And I actually think they should be recipients of these kind of outreach efforts, our
Yes.
distilled summaries.
Mhm.
You know, and I know Sarah Ponce was really advocating that we create similar things that target the public, non-clinicians, and I would put the legislators kind of in the crosshairs of both of those populations.
Right.
There are some provider legislators and some non-providers. So I think circling back to our earlier agenda items, I think that
Great.
they're important recipients.
Yeah. Great. And then just one short update to close up the item 6 on the agenda before we can maybe go to public comment is just tomorrow we are going to be launching, and actually tonight, but it'll be used tomorrow. We are launching some updates to our electronic verification system, our EVS, that we're excited about. One of those updates makes it possible for pharmacy agents to be able to play a role within the EVS, to be able to support the operations of the medical cannabis pharmacy as a business, to be able to support patients as there are recommendations that come from the QMP to the pharmacy about the dosing guidelines, and the pharmacy agent will be able to see those directly, and they will also be required, we'll be putting together a course that they'll be required to do on that'll be on confidentiality and HIPAA. So that'll just remind them about the need to keep that private information that's medical information that's in the EVS private. And so while they're getting access into the EVS, there's also this requirement that they do some additional training that we're putting together. Also, another thing that will improve is that it'll be easier for the pharmacist at the pharmacy to process the limited medical provider requests that come in, or recommendations that come in for particular patients that where the provider is not a QMP, where it's any of the 21,000 prescribers that are licensed in the state by DOPL with a controlled substance license. So it'll just make it easier for the pharmacist to be able to support those type of recommendations. And then also, yeah, there's a few other changes, but one thing that will happen by the end of this summer, we're actually testing later this week, the controlled substance databases inclusion of the verification of a medical cannabis card holder. So any of the 21,000 prescribers in the state will be able to have access to verify whether their patient has a medical cannabis card or not, that's been issued by the Department of Health and Human Services. So later on, a much more complicated process will be including the history of purchase of the actual product that aligns with that specific patient. That'll be included in the controlled substance database that prescribers already have access to. That is coming, but at least we've been able to take the first step. We're testing or getting a demo of what that'll look like in the controlled substance database, with just that card verification being the first phase. So we will notify you, and we'll notify all prescribers with help from DOPL when that access is opened up, and they'll be able to jump in there and verify cardholder status for patients.
I mean, we can do that now, but it's a very clunky system, and I found that I have to follow up to make sure that I get a response. So you're talking about like an easier way to do this with that, because right now you got to send an email with a request.
Oh yeah, you won't have to do it that way.
Okay.
You'll be able to get it on your own in the controlled substance database.
Okay, that's what
through
I thought you
a
meant.
search.
But I just,
Yep.
okay.
Yep.
Okay, great.
Yeah.
Hmm.
So we'll notify all prescribers across the state when that is able to be used, and that'll be soon. We're just, like I said,
Great.
going to get a demo on it today to make
Good to
sure it's
hear.
working like
Good
it
to hear.
needs to.
Good, okay.
So that's all. I just wanted to make sure that the group was educated about some of the software things that are happening to improve the system and to make it easier for patients to get access and to streamline processes at the medical cannabis pharmacies.
Yeah, yeah, great. I mean, we're really seeing how, you know, since the inception of this program, we've had to do a lot of catch up, you know, trying to make it usable. You know, get it launched is one thing, but we're in this process of trying to make it usable and accessible, and that's great to hear. So let's well, time to go to public comment, but I just want, and we can start with you, Christine, but I just want to remind everyone to you know, use the raise the hand. I see yours, Mark, as well. And please state your name, affiliation, and any financial interests. And we're actually, Sarah Lalos, I'm going to ask you to be the timekeeper, if you could.
Yep, I will do that.
The limit. Okay, so go ahead, Christine.
Thank you. My name is Christine Stenquist. I'm the president and patient advocate of Truth, which is a patient organization nonprofit here in Utah. I have no financial gain in any of my comments that I'll be making today. I wanted to express support for what Rich has been saying. There were some misinformations. The one comment he did make about the LP program, the license, what was it? The
Limited provider.
limited, sorry, there's so many acronyms now in the cannabis space. It's so hard to keep up. I apologize. I was the one that made the comments about the QMP program, and I will continue to be against the QMP program. And here's the reason why. My support of the health department is they support the patient-doctor relationship. This is why I attend so many of your meetings. I am one of those advocates that's out here in this space that is supporting the efforts that you guys are trying to make. To that point, one of the problems that keeps tripping up your board specifically dates back to why I was against your board being created in the first place. They were making you take studies that were from FDA approved, and we are still at a Schedule 1, which limits your hands on being able to get studies out to physicians that might be credible. There are credible studies out there, but FDA approval is such a high bar. And as Perry had stated, and that's why I was sending out those emojis of support, is he's absolutely correct that you have good stuff and you have bad stuff. You have industry who is pushing their perspective, and that's a little bit of why you had the Delta 8 and the THC analog pop up. That's why I came directly to Rich with the concern as a public, knowing that the health department was on my side on this as
That's
to
time.
Thank you, Christine. I want to say, you know, we understand that, you know, that's what most of the discussion today was, is the you know, again, our task is to ensure that this program is truly medical, and something may have some medicinal properties. But that does not necessarily mean that it meets the standard that is important that we keep intact.
okay, well, I would just follow up with reach out to medical cannabis experts that are in the field, the researchers who are outside of Utah. I can give you a list of
Yeah.
people who have better information and understanding of cannabis than this current board does. I'm just offering support, not
Thank you
dismissing.
for
I just
that.
don't want to
Yeah.
be dismissed.
Yeah, no, I hear that. And again, we are open to receiving anything that people want to send us. And then we'll apply, you know, the standards that we must apply. But we do appreciate that feedback. Should we go to Mark? I don't see anyone else with a hand up. Okay, Mark, go ahead.
Hi, Dr. Mark Viner, psychiatrist, private practice, Reno, Nevada. No financial ties, nothing, just an interest. Now, just a quick thing about the provider education outreach strategies. I was thinking it's time, is it possible to build direct bridges with the provider by having like an on-demand or a 24-hour hotline where the prescriber can speak with the provider to review questions or even a particular case, because you know it's personalized medicine basically. So the other thing is having question and answer brief luncheons specifically targeted to specialists, like OBGYN has different questions than psychiatrists and rheumatologists. So I think is it possible to go directly to the provider by, like, for example, doing a test program where you have a volunteer to answer the phone when a prescriber has a question, like, should I be using THC 8 or whatever? So then you can disseminate the accurate information and directly bond to the provider. It's almost time, because of the nature of cannabis medicine, that it should be considered in addition to the blasts. Thank you. I'd be willing to volunteer to do a pilot thing for a month to try it out and see if anybody calls. But you might be interesting to study. But while this provider number isn't that big yet, not a control. Thank you.
Yeah, thanks, Mark. I think that those are great suggestions. I think, you know, that there's some discussion about building our kind of bridges into the community through actual providers, you know, who are QMPs or have a lot of experience with the patient end of things on the ground, prescribing, as well as in line with our methods and our approach. So we are making an effort to do that. And I think that's a great suggestion.
Yep.
Okay, I think that that's it. Sarah Lalos, maybe you can scan to make sure I'm not missing anyone.
Nope, I don't see any other hands.
And look at that, it's 10:52. I think it's a wrap. Is that
Yeah.
okay? Well, thank you everyone for your time. I appreciate it, and we'll be back next
We have
August.
to call for a motion.
Oh, sorry. See that's new to me. Someone use some meeting speak and end this meeting.
Motion to adjourn.
Second.
Great. Okay. Thank you. We'll see you all next month.
Thanks, everybody.
Thank
Okay.
you.
Have a good one.